Hello students, welcome to Concepts of Care for Patients with Hematologic Problems. We are going to dedicate some minutes to malignant lymphomas, multiple myelomas, and some other topics, just to finish up this chapter, this long chapter. Okay, your PowerPoint is talking about malignant lymphomas and is mentioning the two types, the Hodgkin lymphomas and non-Hodgkin lymphomas. Besides that, the PowerPoint is dedicating some hints about the disease, talking about the large painless lymph nodes, the fever, the symptoms, what we call the B symptoms, and some have no symptoms of type at the time of diagnosis. Also, in terms of intervention, they are talking about the different types of radiation, chemotherapy, and they are making a specific, they are mentioning specifically the CAR T therapy. So we're going to focus on that, and we are going to expand a little bit more based on whatever I see and I know is going to come in your NCLEX exam. So first of all, we know that the lymphomas are cancers of the lymphoid cells and tissues with abnormal overgrowth of lymphocytes, right? Lymphocytes is the key here. They are cancers of committed lymphocytes rather than immature cells, as in leukemia. This growth occurs as solid tumors in lymphoid tissues scattered through the body, especially the lymph nodes and spleen, rather than in bone marrow. The two major adult forms of lymphoma are Hodgkin lymphoma and the non-Hodgkin lymphoma. So the pathophysiology, the HL, which we are going to mention it this way from now on, is Hodgkin lymphoma. It's a cancer that can affect any age group. However, it can peak into different age group, the teens and the young adults, and later the adults between the 50s and 60s. HL affects younger men and women equally. But the disease is more prevalent in men when the HL hit the adults, especially the men in the older group. Possible causes are viral infection, especially the Epstein-Barr, which is the most common cause of mononucleosis, Epstein-Barr. Just for your information, once the Epstein-Barr hits your body, it's gonna stay dormant in your body forever and ever. Okay, the Epstein-Barr is going to manifest in different ways. Sometimes the Epstein-Barr can be living at the end of your spinal cord. Maybe it could be living behind your eyes, causing eyes issues. Epstein-Barr is going to manifest in different forms, okay, depending on your chronic conditions. So it's better to keep a good health, good nutrition, good exercise routine. Also, another cause would be the human T cells, leukemia, lymphomas, and the HIV, exposure to chemicals, not only because you are living next to a factory, the water is going to be a risk factor, maybe because you are walking in a place where smoking is permanent. Those are not only the risk factors, but also your exposure to chemicals. It could be different type of drugs, cigarettes, maybe you are exposed to the chemicals of a chemotherapy. There is the residuals of chemotherapy in a toilet that you are sharing with another patient who is receiving chemotherapy. Think about all these types of chemicals. However, most cases of the disease occur in people without known risk factors. This cancer usually starts in a single lymph node or a single chain of nodes. This node contains a specific cancer cell type called the Reed-Steinberg cells, and that's good to know. I want you to focus and remember this. There is a difference between malignant lymphomas and multiple myelomas, okay? So for this particular type of cancer has the presence of the Reed-Steinberg cell in HL. often spreads predictably from one group of lymph nodes to the next, unlike making that the difference with non-Hodgkin lymphoma. So red stem cell is always a marker for Hodgkin lymphoma. Non-Hodgkin lymphoma does not have the red stem cell. Okay, let's talk about non-Hodgkin lymphoma. NHL from now on includes all lympho cancers that do not have the red stem cell, like I said it again. There are over 60 subtypes of this NHL and are classified as either indolent or aggressive lymphoma and spread through the lymphatic system in a less orderly fashion than HL. Having said that, one of the things that I want you to remember when you take the NCLEX is that the Hodgkin lymphoma, usually you're going to find they are going to be cervical lymph nodes. The lymphadenopathy is going to be around the cervical, around the neck, probably on the chest. That's HL. However, the non-Hodgkin lymphoma, you're going to find the lymphadenopathy all over the body, in the groin, in the axillae, in the cervical, everywhere. And I have submitted a graphic. There is a table that I inserted in the supplemental file that you're going to find with this chapter. You're going to see the Hodgkin versus non-Hodgkin lymphoma, where you're going to see that the Hodgkin is basically the overgrowth of the B lymphocytes, versus non-Hodgkin is the presence of B lymphocytes, T lymphocytes, and sometimes the natural killer cells, which is kind of rare. You see, there is a big difference, okay? Okay, the cause of NHL is unknown, although the incidence of higher among patients with solid organ transplantation, immunosuppressive drug therapy, and HIV disease is these patients are higher risk. For somebody who receive a liver transplant, or maybe after a traumatic burn they receive skin transplant, so they are in high risk for NHL. Chronic infection from Helicobacter pylori, hello, pay attention to this, is associated with a type of NHL called mucosa-associated lymphoid tissue. It's called MALT lymphoma. An Epstein-Barr viral infection has been associated with Burkitt lymphoma. So what happened with Helicobacter pylori, this has the shape of a spiral. So this particular organism gets inserted into the mucosa of your gastrointestinal, and it's kind of difficult to get rid of Helicobacter pylori unless you really follow the instructions with the medications, and the therapy with antibiotics is complicated. There are too many medications at once. Some patients don't want to follow with this. So there is two ways in which the H. pylori is going to go. Either it's going to cause gastritis, ulcers, and it could lead to cancer, or it could go in the other way with the lymphomas. Okay, we mentioned the Epstein-Barr, and okay, this is an increased incidence. There is an increased incidence of NHL among people exposed to pesticides, insecticides, and dust. Okay, these are type of chemicals as well. NHL are classified as B, T cell lymphomas depending on the cell type that gave rise to the cancer. B cells lymphomas are more common. So the NHL, they have the B cells, T cells, and sometimes the natural killers, but the B cells is the most common type. Patients with indolent, slow-growing, slow-progressive lymphomas often have painless lymph nodes swelling at diagnosis, and that's one of the characteristics also in both in Hodgkin and non-Hodgkin. they are painless lymph nodes. Okay, and I think they mentioned that in your PowerPoint as well. Those with more aggressive B cell lymphomas may have large masses at diagnosis and constitutional symptoms, which are specific whole body symptoms as seen in Hodgkin lymphoma. This occurs in about 1/3 of patients with aggressive non-Hodgkin. Bone marrow involvement in indolent lymphoma is common. So the assessment, you're going to find large painless lymph nodes. That's the characteristics of the lymphadenopathy in this disease. The classic B symptoms, which are fevers, night sweats, and unplanned weight loss, sometimes more than 10% of normal body weight. And these symptoms often means a poor prognosis. So whenever you conduct your assessment, you ask your patients within the last 6 months how many times you have developed fever, are you having night sweats, how often is this happening, did you lose weight because it was intentional or unintentional. Diagnosis and subtype of Hodgkin are established when biopsy reveals the red Sternberg cells. So that's the difference. That is going to make a difference between Hodgkin and non-Hodgkin. Again, I am repeating this over and over again because you are going to see that in your NCLEX as I am reviewing different sources, how the questions are preferred for NCLEX. That's the way I select the content that I'm going to deliver, not only the PowerPoint, which sometimes is only a reflection of the book, specifically of the book that you are using this semester. Okay, so staging includes a history and physical examination, your CBC, of course, which is your complete blood count, electrolyte panel, which includes your potassium, sodium, chloride, calcium, kidney and liver functions, erythrocyte sedimentation, which is going to give you an idea of the inflammation, bone marrow aspiration and biopsy, CT of the neck, chest, abdomen, and pelvis, your PET scan, which is more advanced CT type of scan. The PET scan usually is going to highlight the different places where the lymph nodes are affected, and in some solid cancers, the PET scan is going to help you to determine if there is metastasis. Okay, so the PET scan is more advanced. After testing is complete, the disease stages according to the Lugano modification of the Ann Arbor staging system for primary lymphoma. Okay. Classification of non-Hodgkin is more complicated and is based on the WHO classification system, but they consider the lactate dehydrogenase, which is a marker for inflammation as well, beta microglobulin tests, higher levels of which are associated with poor prognosis. Cerebrospinal fluid, for me, this is the key to diagnose the NHL, is evaluated when lymphoma is present in the central nervous system or around the spinal cord, brain, or testes, and when HIV-related lymphoma is diagnosed. So what are the interventions? Usually radiation or chemotherapy based on the stage, type of lymphoma, locations. All of these factors are going to make the provider decide how to conduct the therapy. An important issue is that when the disease is in the inguinal area, radiation therapy results in permanently reduce of fertility or sterility in men. So you have to talk to the patient in order to bank the sperms before therapy begins, if they have future productive reproductive plans. Okay. Treatment of HL are often effective, and they can result in complication years and even decades later from both radiation and chemotherapy. I'm going to repeat this. Even though Hodgkin lymphoma, okay, can have a better effective treatment, the complications are going to be manifesting years or decades later after finishing the radiation and chemotherapy. The late effects include cardiovascular disease, which is a major non-cancer cause of death in this type of lymphoma. The survivors' secondary malignancies from radiation, especially breast cancer and lung cancer. Okay. And restrictive lung disease and endocrine dysfunction that includes female infertility, hypothyroidism, and premature menopause. Just think about how this radiation and therapy and chemotherapy is directed to your lymphocytes, which are your cells that are defending you from other diseases. So if they are touching those soldiers, that's why probably in the future you are not having enough defense against breast cancer and lung cancer. Okay, so that's something you need to consider. Also, there are monoclonal antibodies like rituximab, which is very popular. And this therapy that is being mentioned in your PowerPoint and is very popular, a CAR T cell therapy, which is designed to enhance a patient's own immune system cell killing of cancer cells. It is known as adoptive cell therapy and dates back to the late 1980s. A patient's T-cell lymphocytes are extracted from his blood and placed into culture with artificial cancer receptors known as chimeric antigen receptors. And these receptors integrate into the T-cell's membrane and modify the activity specifically against cancer cells. So after this process, the CAR T cells, right, the CAR T cells are infused back into the patient's blood where their numbers increase. These CAR T cells then serve as guided missiles that seek out cancer cells and attack them. So they basically take your T lymphocytes, they kind of retrain the cells, and they add cancer receptors called chimeric antigen receptors. That is the name coming from CAR T cells, right? And then they put them back into the system. So a general response for this therapy is to charge the immune system with release of many inflammatory cytokines, a problem known as cytokine release syndrome. So that's the, let's say, the side effect after they put back the T cells with these chimeric antigen receptors. So the patient is going to be is going to feel approximately in the first 5 to 7 days a response with flu-like symptoms, fever, fatigue, body aches, hypotension, edema, and decreased urine output. Some patients also become confused and have nausea and vomiting due to this CAR T cell therapy. So that's something that you need to know. And if you're going to work in a hematology oncology unit, you need to be prepared to provide nursing care, right, for all these patients, especially post-CAR T cell therapy. Nursing management of the patient undergoing treatment for HL unknown HL focuses on the acute side effects of the therapy. So you need to monitor the pancytopenia, okay, because this can cause infection. Pancytopenia, again, is the reduction of the RBCs, WBCs, the platelets, right? You need to prevent and help the patient with the nausea and vomiting, skin problems at the radiation site, constipation, diarrhea. You need to talk about the possibility of permanent sterility, secondary cancer development from drug-induced impaired cellular regulation and the need for long-term follow-up. So this is all about the lymphomas. Let's go to multiple myeloma. And for multiple myeloma, what I see in your PowerPoint is that they are telling you is a WBC cancer of mature B lymphocytes. Main symptoms are fatigue, hissy-bruisy, bone pain. Treatment involves watchful waiting, proteasome inhibitors, immunomodulating drugs, and the hematopoiesis stem cell therapy. That's what they are mentioning about multiple myeloma. So, okay, how I get rid of this? So multiple myeloma is a white blood cell cancer of mature B lymphocytes, we know that, called plasma cells, okay? And that secrete, these plasma cells are the ones that secrete antibodies. Excessive antibodies are called gamma globulins, and the disorder is known as a gammopathy. Okay, so in multiple myeloma, what I want you to remember is that risk factors for the disease include a diagnosis of monoclonal gammopathy of undetermined significance, which is known as MGUS. When they do the diagnostic studies, if the patient has the MGUS, is positive for MGUS, then that's the confirmation for the multiple myeloma. The excess antibodies are in the blood, increasing the serum protein levels and clotting blood vessels in the kidney and other organs. Excessive myeloma cell proliferation reduces production of red blood cells, WBCs, and platelets, which is again another form of pancytopenia, leading to anemia and increased risk for infection and bleeding. Without treatment, this disease quickly causes progressive bone destruction, and that's the part that I want you to remember. That's the difference with many other conditions, because this one is going to cause bone destruction. And with that, hypercalcemia is going to be another differentiated factor from other conditions. Okay. So, although few patients with multiple myeloma are cured of the disorder with current management methods, life expectancy can exceed 10 years. I personally have seen patients that are taking their medications and they are very strict into following up with the provider, because as you are going to see now, it's not only the symptoms, but the problem with the bones, and bone pain is an issue for anybody in general, right? It's a horrible discomfort. So if they are strict to the medications and they follow up with the provider, I've seen patients in the oncological clinic with more than 15 years under therapy, and they are doing well, with some symptoms manifesting here and there, but they're doing well in general terms. The cause of multiple myeloma is unknown. Possible risk factors include radiation exposure, chemical exposure, and infection with human herpes virus. So here you notice the difference. In lymphomas, you have the presence of the Epstein-Barr. In multiple myeloma, you have the presence of the herpes virus. That is another virus that once it gets into your system is going to live there forever. The disorder occurs most often among older adults who may already have experienced age-related decrease in kidney functions. Okay, so that's something you need to monitor. Cardiopulmonary complications are related to the increased blood viscosity, which increases the risk for the formation of venous thromboembolism anywhere in any particular region. Remember that in multiple myeloma, there is a excessive number of abnormal plasma cells that invade the bone marrow and ultimately destroy the bone. And this occur also, the invasions of the lymph nodes, spleen, and liver occur. So these plasma cells are the ones that are going to cause the viscosity, and you have to monitor not only for the kidneys. Just realize the symptoms that I am mentioning: bone pain, bone destruction, problems with the kidney, cardiovascular complications, venous thromboembolisms. It's a disease that is not easy to treat. Okay, so the patients, they have to be very strict and very organized with the follow-up of care. So assessment, the patient is going to present to you with fatigue, anemia, bone pain, fractures sometimes, recurring bacterial infection, and kidney problems. Okay, and the infections are going to be for the problems in the cells, the pancytopenia. As I mentioned, if the patient is positive for the MGUS, which is the monoclonal gammopathy of undetermined significance, is going to be positive for multiple myeloma. The patient usually first notice fatigues, easy bruising, and bone pain. Bone fractures, hypertension, infection, hypercalcemia, and fluid imbalance may occur as the disease progresses, and the diagnosis is made by the X-ray of bone thinning within areas of bone loss that resemble Swiss cheese. You are going if you get a chance to see these X-rays, there is no better description than a Swiss cheese, and you are going to notice definitely this is multiple myeloma. High immunoglobulin and plasma protein levels, and the presence of Bence-Jones protein. And even though it's not mentioned in your PowerPoint, I want you, please, and ask you, I beg you to remember this, make the difference between the lymphomas with the red stem cells and multiple myelomas with the Bence-Jones protein, okay? A bone marrow biopsy is performed to diagnose the disease and to determine microsome changes. An abnormality of chromosome 11 predicts a longer survival. An abscess of chromosome 13 is a poor prognosis factor. You see, when we talk about leukemias, we are looking for the Philadelphia chromosome, right, to make differentiations between the different types of leukemia. Here, the absence of the chromosome 13 is going to give you the prognosis factor, versus the chromosome 11 is going to predict a longer survival. So we know about the Bence-Jones, and also that's good to know. Besides the Bence-Jones, I want you to know, and I want you to remember, that also for hypercalcemia, fluids is needed not only to dilute the calcium overload, but also to prevent protein from precipitated in the renal tubules, or meaning to cause more problems to the kidneys. So you need to drink a lot of water in multiple myeloma. There is a lot of debris from the bone destruction. You don't want to cause any more problems with the kidneys. So what interventions is the nurse going to do with this? For bone pain, probably you have to talk to the patient about bisphosphonates that can reduce bone pain by reducing bone destruction. When changes in the spinal column result from bone involvement, emergency treatment is needed to prevent nerve damage. Okay. Also, proteasome inhibitors and immunomodulating drugs. The list is long, includes your steroids, your cyclosporine, and you need to know about this because you are going to use these drugs in many conditions. Especially you need to master the side effects. Remember, you are the last step between the provider's prescription and the patient. Nurses are with the patient most of the time, so if you detect that the patient is developing certain signs and symptoms that are going to be worse if you give them certain medications, it's your responsibility to tell the provider and sometimes to stop the medication, okay, or questioning the prescription. Standard chemotherapy is another treatment. Myelosuppression is an expected side effect of many myeloma therapies. Remember that this radiation and chemotherapy are working in the bone marrow, the production of good cells, right? A nursing priority is to teach the patient about the symptoms, what to look for. What are the symptoms that the patient should be looking for in order to come to the emergency room or to make a sooner appointment with the provider? Remember all these signs and symptoms that are not easy to handle in the regular life. They have to look for thromboembolic events, peripheral neuropathy, nausea, vomiting, diarrhea, and constipation, pain if they are feeling like they are suffering fracture. Bone loss is treated with bisphosphonate, as I mentioned, like zoledronic acid, denosumab, those are the most popular, which inhibit bone reabsorption and can help reduce skeletal complications. Now we're going to talk about thrombocytopenic purpura. The PowerPoint is mentioning right now the three types. Is the destructive reduction of circulating platelets. They are mentioning three types. They are also mentioning the ecchymosis, purpura anemia, and the treatments. So we are going to get deep into the thrombocytopenic purpura, which is a destructive reduction of circulating platelets after normal platelet production. So this is going to destroy the normal platelets. We have autoimmune thrombocytopenia purpura, and we have which is called also idiopathic, and we have the thrombotic thrombocytopenia purpura, TTP, and we have another type, which is the heparin-induced thrombocytopenia, which is the HIT. So autoimmune, the ATP, autoimmune thrombocytopenia purpura. In this case, the patient immune system begins making antibodies against its own platelet membranes, and then these antibodies attack the platelets. White blood cells attack and destroy the circulating platelets, and those stores in the spleen faster than new platelets are produced. So the destruction is faster than the production, and that's why clotting is impaired. In thrombotic thrombocytopenia purpura, TTP, which is also thought to be an autoimmune disorder, okay? With the reaction occurring in a small blood vessel cells endothelial and triggering abnormal platelet clumping in the vessels. So there is a clumping in the vessels. In the autoimmune is more destruction is higher than the production. Clotting is impaired. In thrombotic, clumping in the vessels occur. That's the difference. Tissues become ischemic, leading to kidney failure, myocardial infarction, and stroke. In heparin-induced thrombocytopenia, this is a serious immune-mediated clotting factors disorder with an unexplained drop in platelet count after heparin treatment. So the assessment, you are going to see the patient with ecchymosis or purpura on the arm, legs, upper chest, and neck. Mucous membranes are going to be bleeding easily. If the patient has had significant blood loss, anemia may also be present. Platelet levels are low in all three types. And if the patient has any episodes of bleeding, hematocrit and hemoglobin levels may be low. in autoimmune type can be distinguished from the thrombo type by the presence of antiplatelets antibody in the blood, and that's very important. So whenever you see a patient with this condition, by looking at the blood work, you can understand what is the type. Diagnosis of heparin-induced thrombocytopenia is made by the clinical symptoms and a history of heparin therapy within the previous 100 days. What interventions are we going to do? Platelets transfusion are used when platelet counts are less than 10,000 or when the patient has an acute life-threatening bleeding episodes. Drug therapy to control the autoimmune and the thrombotic types include drugs that suppress the immune function, like such as corticosteroids, rituximab, which are the most common, as I mentioned before. Those are going to inhibit production of antibodies directed against platelets or endothelial. For autoimmune type, IV immunoglobulins and IV anti-RHO can help to prevent the destruction of antibody-coated platelets. Aggressive therapy involves low doses of chemotherapy drugs because they want to suppress the immune function. Drug management of the thrombotic and the heparin type also includes anticoagulants. For the thrombotic, drug therapy includes platelet inhibitors such as aspirin. Okay. Surgical management of the autoimmune type may involve a splenectomy for those patients who do not respond to the drug therapy. In this particular type, the spleen is the site of excessive platelet destruction. So splenectomy is usually not performed for TTP, for the thrombotic, or for the heparin type. Let me repeat. A splenectomy is going to be performed only for the autoimmune type of the thrombocytopenic purpura, not for the thrombotic or the heparin-induced type. Okay, now we're going to talk about transfusion therapy, and you are having in your PowerPoint a couple of slides talking about the transfusion. Basically, they are jumping into your responsibilities, and they are talking about the types of transfusion, the reactions, and the autologous blood transfusions. So, okay. Any body component may be removed from a donor and transfused into a recipient. That's the principle for transfusion, right? Blood components may be transfused individually or collectively, meaning you can transfuse only RBCs or platelets, or you can transfuse the whole components of blood with varying degrees of benefit to the recipient. Responsibilities: before infusing any blood product, review the agency policies and procedures as well as the best practice. And I would say the most important is to start with informed consent, right? And then you have to let the patient know specifically why and how this is going to be performed, so and the consequences and maybe the possible side effects. That is included in the informed consent. Okay, so indications for treatment with blood components: you have the full pack of RBCs in case of anemia and with less than 6 G by deciliters. That's the, let's say, in theory, the standard to transfuse RBCs. There are patients that need transfusions of RBCs when they are, for example, having an hemoglobin less than 8 and they need to travel. Okay, so just for prevention, probably they are going to infuse more. Okay, and that is going, the provider is not going to wait for the patient to have less than 6 of hemoglobin in that case. Then for thrombocytopenia, platelet counts less than 20,000. That depends on the protocol of the hospital. Some hospital, they are waiting for the patient to hit below 10,000. If the patient is below 20,000 and has no signs and symptoms, then they are going to hold it. Probably they are doing some other treatments and therapies. They want the patient to react. Who knows? So, but this is the theory. The theory is below 20,000, you can start the transfusion of platelets. White blood cells sometimes is going to be transfused due to sepsis, neutropenic infection, or responding to antibiotic therapies. Okay, some other doctors are going to start giving injections to increase the neutrophils. Those injections are called Neupogene, right? And they're going to try that first before making transfusions of WBCs. A provider's prescription is needed to administer blood components. The prescription specifies the type. Of course, in many hospitals, a separate consent form is obtained from the patient. Of course, they have to do they have to obtain type and cross match. Usually a new type and cross match specimen is required every 72 hours, depending on the unit, right? Specifically in hematologic units, they are going to be very strict with this requirement. Use normal saline as the solution to administer with blood products. Although this practice is not evidence-based, ringer lactate and dextrose in water are not used for infusion with blood products because they may cause clotting or hemolysis of blood cells. And this is something that you need to master this. Okay, when you are going to administer blood product, always your normal saline, never lactate ringer or dextrose in water. Dextrose is sugar, right? Basically sugar. You are not going to administer blood with sugar. Okay, examine the blood bag label, the attached tag, and the requisition slip to ensure that the ABO and RH types are compatible with those of the patient. Check the expiration date and inspect the product for discoloration, gas, bubble, etc., etc., etc. I have included in your supplemental, and also here there is a video about blood types, ABO and RH group blood systems. We're going to get deep into that in a few minutes. So basically, okay, best practice for patient safety and quality care. Before the infusion, I highlighted the ones that I will pay a little bit more attention. I'm not saying that the others are not important, but assess the patient vital signs, urine output, skin color, history of transfusion reactions, because that is going to give you an idea of what to expect once you start the transfusion, okay? Especially the skin color, okay, and the patient vital signs. Transfuse blood products after all safety checks, soon after receiving from the blood bank, to suppress bacterial growth and prevent product deterioration. And I have personally seen one case in the hospital when we the nurses received the blood product and left the RBCs waiting to be transfused for approximately 40 minutes. And then the patient developed an adverse reaction. So this is very important. That's why I highlight it. Immediately you receive the blood product, be prepared. You prepare all your setup before the blood gets into the unit, and then immediately you start the transfusion. This is not a joke. Blood transfusion is very, very, it's a life-threatening process if you don't follow the protocols, okay? During infusion, administer the blood product using the appropriate filter. Stay with the patient for the first 15 to 30 minutes of the infusion, because this is the time when hemolytic transfusion reaction occurs. What is a hemolytic? Means that the hemoglobin is going to start destroying, the cells. So it's hemolytic. So it has to be 15 to 30 minutes. Although there are some patients that develop hemolytic transfusion after 30 minutes. So you always keep an eye, try to be next to your patient during the duration, at least I would say 45 minutes of the transfusion, just in case. Monitor vital signs again at least as often as agency policy and the patient's condition indicates, to identify early indication of adverse transfusion reaction. Have your blood pressure cuff not on the side of the patient, but already set up in the arm of the patient. So if you see a patient is developing some type of reaction, you take your blood pressure immediately. So there is already there, right? Have your pulse oximeter ready, your thermometer, all the tools that you need to set up and to take vital signs next to you. After the infusion, when the transfusion is completed, discontinue the infusion and dispose of the bag and tubing according to the agency and blood bank policies to prevent the spread of blood-borne pathogens. So you don't get rid of the bag of the RBCs, let's say, in a regular garbage trash. No, there is a specific containers to dispose these bags and tubings. Document all aspects of the transfusion, the type of product, the product number, volume infused, the duration of infusion, vital signs, and any adverse reaction to identify patient responses to the transfusion as part of the permanent record. So then never add to or infuse other drugs with blood products because they may clot the blood during transfusion. Okay, so whenever you see, oh, we are going to put some antibiotic inside, no, it's not possible. Nobody's gonna do that. But just in case, you never know who you're working with. Okay, the transfusion responsibilities, you can read about this. Nursing safety priority. The nurse who will infuse the blood products must be one of the two professionals comparing the patient identification with information of the blood. Always two nurses are checking, the products, the blood types, and I would say, in my experience, it would be nice if you have at least on your first 10 blood transfusions within your career to have a experienced nurse next to you the first 15 to 30 minutes so they can keep an extra eye of what to do with the patient. Some patients, they are gonna have adverse reactions, like they are gonna start shaking or having cold, and you need to have covertors next to the patient. You need to have your Benadryl, your Tylenol, whatever is needed. Everything is ready on the side just in case of an adverse reaction. Electrolyte imbalances are possible as a result of transfusion, especially with packed red blood cells. During transfusion, some cells are damaged, releasing potassium and raising the patient's serum potassium level above normal, hyperkalemia. Types of transfusion, and this table best practice for patient safety and quality care. Keep an eye on this, especially the older adult. Try to use blood that is less than 1 week old. Older blood cell membranes are more fragile, break easily, and release potassium into the circulation. That is very important to read the label once you receive the RBCs or any product that is going to be transfused. All this information is going to be on the label. Okay, adverse reactions, it could be rapid bounding pulse, hypertension, swollen superficial veins, transfusion reactions, hypotension, rapid thready pulse, increased pallor, cyanosis. So you have to infuse the blood very slowly, probably between 2 and 4 hours. red blood cell transfusions are given to replace cells lost from trauma or surgery. Patients with problems that destroys RBC or impair RBC maturation also receive RBC transfusion, and we have talked about different conditions in the chapter that probably they may need RBC transfusions. So you have RBC antigens are inherited. For the ABO system, a person inherits one of these, an A antigen, B antigen, both A and B, neither A or nor B antigen. So for platelet transfusion, platelets are given to patients with platelet counts below 10,000 and to patients with thrombocytopenia who are actively bleeding or as a schedule for invasive procedures. So you see, there are some protocols you have to get ready to be flexible. In some books, they are going to tell you 20,000 and another one below 10,000. It's all based on assessment and the condition of the patient. If you see that the patient is already bleeding and is on 22,000, you proceed with the platelet transfusion. I mentioned before your ER nurses, the ones who want to become ER nurses. When you receive a patient with history of leukemia or any type of blood disorder, this assessment of the conjunctiva, when you ask the patient to watch your index finger and move the finger from right to left, up and down, is excellent to kind of expect to see what's gonna happen in the very close future, okay? Because if you can see in the conjunctiva these red lines, little red lines, meaning that it's already bleeding, even though if they are tiny, that means that the platelets are an issue already. Get into the habit to practice those besides checking the gums, besides asking the patient if they are bleeding when they have a bowel movement. Get into the habit of check the conjunctiva. Is a very good tool. So blood types, the universal donor is the AB, the O type, and the universal recipient is the AB. And I have included a video for you to understand this, and I want you to access this video in the supplemental file that I'm going to give you guys. Platelets are fragile and must be infused immediately after being brought to the patient room, usually over 15 to 30 minutes. Safety priority. When infusing platelets, do not use the standard blood administration set because the longer tubing increases platelet adherence to the lumen, which reduces the number of platelets the patient actually received. So when you transfer red blood cells, you're going to use the tube that has like a Y shape, right? In which in one part you are administering the normal saline, and in the other you have the RBCs. For platelets, it's a short tube, okay? It's not the longer tubing. You always take your vital signs before and after. Let's talk about plasma transfusions. May be given fresh to replace blood volume and clotting factors. More often, plasma is frozen immediately after donation, forming fresh frozen plasma. Infuse FFP immediately after throwing while the clotting factors are still active. Then we have the granulocyte white blood cell transfusion. Rarely, neutropenic patients with infective receive white blood cell replacement transfusion. And WBC surfaces have many antigens that can cause severe reactions when infused into a patient whose immune system recognizes these antigens as non-self. So always follow the agency policy about any type of transfusion, not only the WBC. Keep an extra eye on this one, especially because of the adverse reaction. Massive transfusion protocol. In massive transfusion protocol, in which large amount of blood products are needed to counteract hemorrhage, all blood components are used to restore volume, clotting ability, oxygen carrying capacity. Often the protocols call for balanced delivery of components with PRBC, platelets infused in an order and proportion that mimic whole blood. So this is in reference to the massive transfusion protocol. Acute transfusion reaction, I want you to pay attention to one of the graphics that I have given you in the supplemental file. There is a graphic with all the things to do in case of different types of reaction. For example, if you have an allergic transfusion, you give Benadryl. If you are having a febrile adverse reaction, you start with your Tylenol, right? Also, you're going to see in this graphic the signs and symptoms of each adverse reaction post transfusion. Autologous blood transfusion involves collection and infusion of the patient's own blood. This type of transfusion eliminates compatibility problems and reduces the risk from transmitting blood-borne diseases. The 4 types of autologous blood transfusion are preoperative autologous blood donation, acute normovolemic hemodilution, intraoperative autologous transfusion, and postoperative blood salvage. Self-blood donation before surgery is the most common type of autologous blood transfusion. It involves collecting whole blood from a qualified patient, dividing it into components, and storing them for later use. If hematocrit and hemoglobin levels remain within a safe range, the patient can donate blood on a weekly basis until the prescribed amount of blood is obtained. Fresh RBC may be stored for 40 days. For patients with rare blood types, blood may be frozen up to 10 years. These are factors that are good for general knowledge, and that's why I brought it to your attention. The mastery questions: which new symptom in a client who is being managed for sickle cell crisis does the nurse report immediately to prevent harm? You have the decreased hand grip strength on one side, the fever 102, shortness of breath. The other 2 questions, here you have the answers. Practice these questions. I am not doing select all that apply questions. However, I may ask question number 1 and you may find option the answer C and E together. Okay, probably I'm going to put option A, diffuse abdominal pain. Option B, fever of 102 and shortness of breath. Option C, increased urine output. Option D, sore throat. Probably I am deleted decreased hand grip, and I'm giving you 4 options, and I'm going to put together 2 of the right answers. So practice your questions. There's a question here that also talks about the psychosocial integrity. Explain that a person who is Rh positive can receive Rh negative blood. If you see the video that I have submitted, that I have provided about the blood types and the Rh factors, you're going to be familiar with that. That's all for chapter 37, Concepts of Care for Patients with Hematologic Problems. I know it's a heavy chapter, but I tried to include most of the information that I am sure you will see in your NCLEX exam. Okay, thank you.